Institute of Medical Sciences as the Professor of Medicine, later Dean of Medical Faculty and Director. He was one of the founder fellows of the National Academy of Medical Sciences, and this oration has been started in 1993 in his name. And the orator for today is a very eminent person. May I invite Dr. Piyush Gupta to deliver the oration. Dr. Gupta has been the editor-in-chief of journal Indian Pediatrics. He is professor of pediatrics at the University College of Medical Sciences, New Delhi, and his areas of interest have been nutrition, medical education, and biomedical editing. He's been a technical expert and advisor to the Government of India, WHO, UNICEF, PHFI, and ICMR. You can have no better than Dr. Piyush Gupta to deliver this oration, and his topic that he has chosen for this oration is assessment in medical education, time to move ahead. Dr. Piyush Gupta.
Thank you, Chairperson, sir. A very good morning, distinguished fellows, organizers, and boys and girls. I take that cue from the Indigo, who use that slang of boys and girls, and I really like that, using that boys and girls. Thank you. So as is evident from the first slide, there is a change is desired in the assessment methods. Well, the way ahead, how am I going to structure this presentation will be in 4 steps. As we all know, assessment is an integral component of curriculum. So it cannot be seen in isolation from the curriculum. So we need to know what are the global curriculum strategies and where do we fit in the assessment in those global curriculum strategies. From here on, we will discuss what is the present curriculum. I'm happy there are so many medical students here, so they'll relate to it, and it will be primarily we are talking about the undergraduate medical education only. So what is the present curriculum and where do we stand at present? From here, we will understand we need to have a change, and for a change we need to graduate to a competency-based curriculum. What is this competency-based curriculum? We will come to it later, and why do we need this competency-based curriculum? And finally, we will discuss how to go for assessment in a competency-based curriculum. So this is how I am going to structure my presentation. This is a very broad overview of curriculum designs. As you can see, just look at the bold cap word, SPICES. If you combine them, it becomes SPICES. So this acronym is known as a SPICES model for medical education. In the SPICES model, again, you can have 2 kinds of presentation. A curriculum can be student-oriented or teacher-oriented. In the teacher-oriented curriculum, it is a teacher. In the present-day curriculum, this is the traditional curriculum we are having. We decide as a teacher how much to teach, when to teach, what to teach, when to assess. Okay, what is going to be the timetable? When are going to be your vacation? When is your free time? Everything the teacher has to will decide. Student has no say absolutely. Even if the 2 kind of students are different, they have to be, again, going back to the first slide, elephant and fish they have to go the same way. Either problem-based or information gathering. This curriculum is heavily based on information gathering. We just get material from here, from the notes from the teacher's class, books from the library, maybe clinical material on the bedside teaching, and then we gather it, little knowing what we will do after gathering this whole information. On the other side, there is a problem-based curriculum. Just like if you have to learn swimming, there are 2 methods to learn swimming. The one is you get a coach, and the coach will direct you day 1, okay, you just move your legs, day 2, you move your hands, and then you move in water. This is the one way of approach, information gathering. You read about it. The second is the coach will simply push you into the water on day 1. And he'll say, okay, go swim. I am there to save you. This is a problem-based approach. Discipline-based approach, like we have strict compartmentalization into preclinical, paraclinical, And post-clinical pharmacology hardly has any link with medicine. Anatomy has hardly any link with surgery. So this is a discipline-based curriculum as against an integrated curriculum in the SPICES model. We are basically practicing in the hospital, but when we treat, we are treating in the community. So that is a big dichotomy. There is no scope for any elective subjects, and it is a opportunistic learning rather than a systematic learning. Because it may happen that if you are learning, you have a posting in pediatrics or medicine for 1 month or 2 months, you may never get to see a case of leukemia. It may happen. And in a systematic model, you will have an opportunity to see each and every case, whether by simulation, whether by video, or whether by some other tool. So what is the ideal model? Is the SPICES an ideal model? Or is the traditional one? Obviously, the traditional that we are following does not fulfill the need of the day. So we need to move a bit towards the SPICES model. But yes, excess of everything is wrong. So you can't have everything in the SPICES right now rolled into one particular curriculum. Maybe we need to take bits and pieces somewhere from this model. This is where we stand now. That means our curriculum is heavy on content. What do I mean by heavy on content? We don't know what to do with it. Let's see. And for 40, 50 students swarming around a single patient, you can't have bedside teaching like that. If you have to have small group teaching, it has to be, is the mic working? Okay. Am I audible? That is more important. Okay. So, yeah, now it's. So the emphasis is on mugging up, that is getting the knowledge, and again, observational. You don't need to get to do a thing by your own. You just observe what others are doing. 40 people are observing what one person is doing. And out of those 40, only 5, 6, or maybe at the most 10 will get a chance to do. The others will never get a chance to do. They are simply observing. What we get? We get a well-read student who is very good, who is swarming with bookish knowledge, who can solve MCQ questions, who can go and sit in a FMG exams, who can prepare for further reading ahead. But is that what we need? Can he or she write a prescription, simple prescription, just do an introspection yourself. After passing MBBS, can a student write a prescription, simple prescription for a child with dysentery? Can he or she conduct a normal vaginal delivery? Can he or she put in an IV line or give an intradermal injection or resuscitate a patient? Yes or no? MBBS has by and large become a theoretical course. A student can't do any one of them. In third year, I remember my neighbors came to me, Doctor साहब वो इंजेक्शन लगाना है, एक इंजेक्शन आप लगा दो, you are a medical student. I said, no, I have never handled a syringe. He said, you are 3 years into the medical course and you can't give an intramuscular injection. That is the situation that is there. What we want, if you are in the place of a patient, let's say you are a patient, I am a patient and I go to a doctor. What I want exactly from the doctor? I want a person, first of all, who listens to me. That is the most important thing. It should not be a 2-minute job that I say, okay, I am fever, he writes paracetamol, sends me back. No, I won't go to him again. I need to develop a bond with the person, a person who takes care of me, who takes care of my family, a person who can heal also not only physically, mentally, and spiritually, and above all, a person who can save life. Not only these, I need a person who is well behaved, who exudes confidence. Maybe I am low in confidence at certain times when I am ill. So I go to a doctor just to boost up my confidence or my whatever. So I need a person who exudes confidence, a person who is ethical, honest, and systematic. And the most important, a person whom the patient can trust. So it all boils down to one single word, trust. And that's why the emphasis now in medical education, especially in post-graduation medical education, is on achievement of entrustable professional activities, what we now call as EPA. So I will not go into the details of EPA, but this is just to tell you that it is not one single competency, it is not one single attribute of the doctor which is required by the physician. As a whole, the physician wants, yes, I need this doctor because I trust him. So we have to move out of compartmentalization of assessment. We have to move out of the fragmentation of assessment. The assessment has to shift to a global assessment rather than objective. So there was a great shift from subjective to objective because the teachers were thought to be biased. So the emphasis was shifting from subjective assessment to objective assessment. But the research has shown that it is the subjective assessment is much more important, and it is equally good in the hands of experienced teacher. And objectivity can be achieved only by fragmentation. If you need to have a global outlook, you need to have a total view that may include some level of subjectivity. Can I have some water? Trust me, I am a doctor. Screaming. Such students, medical students, when usually they appear in my class, I say, sir, please dress properly, behave properly, and then come to my clinic. Obviously, you are not going to go to a doctor like this. What you need somebody who looks like a doctor or, thank you. So these are attributes. What are these attributes known as? This is simply known as professionalism. And in today's curriculum, there is no scope for assessment of professionalism because our assessment is primarily based on knowledge, assessing the knowledge, not a single competency. So current scenario, coming back to what we have and what we need. What we need? We need, as we defined earlier, our needs are based on outcome, what we want. And the supply today is based on content. It is heavily content based. So the moral of the story, there is a need to shift from a content based medical education to an outcome based medical education. The present shift has to be, or the key word is what we need. We should be prepared. The curriculum should be outcome based, and the assessment also will be based on assessment of those outcomes. These outcomes are again measured in terms of what a student should be able to do after passing out an MBBS course, and that is defined in terms of, this is known as competency. What does competency based medical education mean to you? Let's inspect the definition given by the international CBME, that is a competency based medical education collaborations. Possessing the required abilities in all domains in a certain context at a defined stage of medical education or practice. Now, remember this word, and just possessing the required abilities, okay, we understand that one should be able to do a certain thing in all domains in a certain context at a defined stage of medical education. What does that mean? At a defined, that means this competency is only achieved at a single point of time. But you can't trust a person with this competency to have this competency lifelong. At present, I don't have the competency of putting in an IV line very smoothly because for last 20 years, I have not put an IV line. I'm competent more in giving lectures. I'm competent at giving oration. I'm competent at maybe editing a paper. But at this stage of life, after 20 years of professor, I am not competent enough to put in an IV line. So just to say that competencies are dynamic, competency is not static. That's why a one-time evaluation of a medical student is unfair to the community. It has to be an ongoing process. But again, who is going to do it? How is it going to do it? These are the questions that loom large on the horizon. And competency, again, as I said, it should not be fragmented. It is not that if you are able to resuscitate a newborn on a dummy, that means you can actually do that in practice. There is a lot of difference between doing that in a model and doing that actually when you are in a labor room setting. That is known as the assessment in context. So the assessment has to be contextual. In the OSCE, if you have heard of OSCE, Objective Structured Clinical Examination, you may have stations that evaluate counseling. Okay, you are in front of a dummy patient and you are counseling the dummy patient, and the examiner is just listening to you how well you are counseling. So a very good actor can do that very well. A person or a student who is very good in drama, I used to do it very well. But when it boils down to the actual situation in the clinic, how is he doing that? Whether he is behaving the similar way is different question altogether. The perspective may change. That is again talking assessment in terms of context. So who is better equipped to assess you? A faculty or the patient? Or maybe your team workers, maybe the nurse who is working along with you, maybe your peers. That assessment by those people is never taken into the account when you are overall being assessed for being a good physician. A competency, again, these are just technical things that any competency should have several criteria. It should be specific, it should be comprehensive, it should be testing all the three domains like the cognitive, affective and psychomotor domain. It should be durable, trainable, it should be measurable because you have to be assessed on that particular competency, and it has to be related to professional activities and connected to other competencies as well. This is 6 competencies defined by American Board of Accreditation. These are the 6 competencies on which most of the education in US based upon. These are procedural skills, system-based practice. You see, medical knowledge is just one part. The rest are all skills, professionalism, system-based practice, patient care, and communication and interpersonal skill. And in our today's curriculum, we are just dealing with the medical knowledge and maybe some, again, theoretical knowledge of the skills, but we never get to see a student how well he or she performs. Moreover, our assessment is primarily summative in nature. I'll come to that, what I mean by that. So what is the difference between traditional versus competency-based medical education? The assessment in the traditional, it is the goal of educational encounter is acquisition of knowledge or just gathering the content. Where in the competency-based, it is the application of exact knowledge, what we need to use. Assessment is authentic, criterion referenced, and emphasis is on formative assessment. What do we mean by here? The emphasis on summative assessment. Summative means one-time annual exam like you have, where you have chance to improve only in the next summative assessment. There is no chance to improve. There is no feedback other than only the marks. While in formative assessment goes throughout your career. Formative assessment may go beyond your completion of MBBS and may continue throughout the life. So the assessment is, or the emphasis is more on formative assessment in competency based. This is just to highlight a curriculum where I have worked at the Nine Wells Hospital at Dundee, which is the Center of Medical Education, and I happen to work with Professor Harden, who is the Chief of Medical Education Center. So as you can see, this is a spiral curriculum where it is a system-based approach. Students, the whole curriculum is divided into 100 tasks or problem. And each problem is taught how to solve that particular problem. And then what you get, what the doctor is able to do, doing the right thing, how the doctor approaches the patient, that is doing the thing right, and finally, the doctor as a professional, the right person doing it. So these are the three rights, just an interplay of words, but it changes the whole meaning of those sentences. So this is how that, I don't say this is ideal, but we can even have a better curriculum than that. And this is always, again, the curriculum has to be nation specific, institutional specific, and contextual specific, which again, if you want to devise such a curriculum here, it should be like that. It is good to know, for your knowledge, that MCI is under the process of coming out with a competency-based curriculum, and we may see the introduction of a competency-based curriculum in near future. But again, the problem still remains the assessment in a competency-based curriculum. How to do it? If we do an assessment without knowing what we are going to achieve, we are probably getting answers like this. So what are the critical question is assessment? Sir, please inform me on the time. Whenever you want me to finish, just 5 minutes before. Why are we doing the assessment? What are we assessing? How are we assessing it? And how well is the assessment working? So these are the 4 critical components of assessment we need to answer. We will answer these questions one by one. Why are we doing the assessment? The purpose of assessment is to prove something, that yes, this person has the capability of doing a certain thing. So this is a function of assessment that is known as prove. I just add that is the second purpose, and the more important purpose is to improve. It is not only to prove at one time. So the functions are prove and improve. And this improvement carries on throughout the life. Should carry on ideally throughout the life through a formative assessment. What to prove? You have several things to prove in the assessment. Knowledge, skills, emotional maturity, communication, sincerity, sympathy, empathy, and so on. There's a huge list. These are just few of the points, the most important, which we value in a professional, which we value in a doctor. How to assess them, I also don't have the answer. But maybe we need to work them out in a bigger setup. To improve, observe behavior, compare with norms, provide feedback. So these are the methods by which the improvement can be again. So this is simple, that if you are just asked what is the purpose of assessment are two, to prove and to improve. I think it will be simple to remember. I think I'll skip that because this is a detailed, it may take some time to understand what is criterion and what is norm reference. However, norm referenced happens after the examination and criterion happens before the examination, to think which is better for the competency-based assessment. This is the Miller's pyramid. In the first bottom line, this is the most basic assessment of knowledge. So this is by simple MCQ or written test, you can do what the student knows how to do a certain thing. Maybe again you need a short answer or clinical context-based test. Shows how to do, like in a OSCE, objective structured clinical examination. And finally, does a thing. Does a thing means this is a workplace-based assessment, WBA, mini CEX, mini clinical exercises, and directly observe performance. So these are the few of the tools. Another tool, there are more tools to it, like 360-degree assessment, multi-source assessment, portfolio assessment. There are a whole lot of assessment techniques which can be inculcated or which can be incorporated in the present day curriculum. Again, if we see the Miller's pyramid, at the top, it lacks assessment in context. This assessment is again at the point where the student is being assessed. This is not in the community. An assessment to be valid has to be valid. It has to measure what it intends to measure. It has to be reliable. That means it has to be reproducible. If the same assessment is being done by 2 different persons, the results are going to be same. It is to be feasible, acceptable, and it has to leave an impact. So a hard task. This is how you assess the utility. So can we have an assessment tool which is so much have utility? But obviously, assessment low in one of the factors can still be useful by being high on others. So it is not essential that a single assessment tool may have all the components which are desirable in a. Again, we were talking of context. This is a simulated or in the exam mode OSCE type assessment. The examiner is observing and the student is asking the patient or counseling, whatever. And this is the action, where the action is. How do you perform under stress? How do you perform in the exact situation? Only directly observed workplace-based assessment is authentic and likely to be more valid. Reliability has to be built, because here another component comes into place, that is the faculty or the person who is doing the assessment. So on which the reliability matters. And this directly observed workplace assessment, you can understand, is not going, cannot be a one-time assessment. This has to be a ongoing assessment. Assessment has to be on a regular basis, and it is primarily, one has to rely more on formative tools as compared to the summative tools. So it has to be ongoing, not at given point of time. Yes, it is important. A summative assessment is also important, because to the community, you have to give a product who is fit to treat that community, who is fit to give, who has a license to practice. So that is also important, but not at the cost of foregoing formative assessment. Who assesses? Important question. Faculty is here, students are here, and this has always been a, who assesses you? Your peers should assess you. The patient should be assessing you. Your team members should be assessing you, or the faculty should be assessing you. Think of a system where there are consumers and where there are providers. Everywhere, it is the consumers who assess the providers. Who is the consumer? The patient, the community. The provider is the physician. So ideally, who should be assessing that this person is good for me or not good for me? But you can't simply have all of us jobless at the given time. So faculty is definitely needed for assessment. But the problem with faculty is, was amply highlighted in an article in JAMA, that professors are not professing. Probably they are busy in something else. A teacher is supposed to have 9 hands. It is their problem also. Please understand their problem also. They have to be equally proficient. They have to do the patient care. They have to do the research. They have to do the administration part. If something finishes off in the hospital stock, they have to get it. They have to do the teaching also. And then they have to attend various conferences, deliver these orations like I am doing, and maybe also get into politics. Sir? Yeah. Promotion of faculty hangs by the thread of publications. Professor, someone did not publish, so perished. It is a known fact, publish or perish. Nowhere in your promotion or in your assessment, a teacher is assessed by how well he or she teaches, how popular the person is among the students. Why then we go for teaching? Primarily, that is one big advantage of being teacher, is that I have a prestige of have a professorial appointment. I'm a professor at this medical college. That gives me pride. That does not bring along with it what I'm supposed to do actually. A professor has to profess, are we professing or not? End result is that when you are driving, your concentration has to be on the road. Your concentration has to be the steering. If you are having 3 or 4 mobiles simultaneously, the concentration wavers. This is what is happening. The teaching is become our secondary objective. So it is important to have a faculty development. I know my time is running, so I'll not go into the details. How to do this faculty development is a big challenge. It does not simply mean training, because training happens one day, the next day everything is back to square one. It has to be change in the attitude, and somehow the faculty has to be empowered, maybe given additional resources for research, additional resources for administration, additional resources for patient care, so that they can focus more on the teaching aspects. Their assessment primarily has to be on the assessment, on the teaching things only. So our features of good assessment, just a repetition. It should be relevant to the curriculum, focus on important skills, promote learning of skills, spell level of attainment, discriminate between good and poor students, and the improve function, provide feedback. Provide feedback and see that feedback actually improve does not mean that you are failed. Go back, come back after 2 months for a supplementary examination, write your exam again, pass, and then you are competent. This does not mean any improvement at all to me. There is no perfect assessment. As said, compromise is always required. So it's a deal on the table. The compromise again depends on the context of the assessment. We are ready to compromise, but let's sit together and see what is the best tools of assessment for our students. Finally, the recommendations. The new curriculum is required, maybe it is coming. It has to be a competency-based curriculum with inbuilt scope for teaching or learning of humanism, ethics, professionalism, and basic and clinical sciences. There is a need to define and develop core competencies. Like in the 9 Wells curriculum, I showed you, they have defined 100 competencies or 100 tasks on which the whole curriculum is built. I'm sure there'll be not many more. So simply we can do develop a core competencies and assess on this should include your teamwork and communication, acquisition of information, self-assessment, professionalism, and community service. Change now, the assessment needs to be oriented to both prove and improve, be continuous and frequent, be work-based and contextual, and I like to add be global, be criterion-based rather than norm-based, and incorporate more qualitative approaches, that is a more subjective approach may need to be incorporated. Research is definitely needed to identify the best practices of assessment in the system and institutional context. In this context, I am happy to note that the NAMS has created a Center for Research in Medical Education at AIIMS Jodhpur with Dr. Kuldeep Singh heading so I was just talking to him yesterday, and I'll be very happy if he'll be able to initiate this process of just thinking of the research areas in assessment and others also in medical education. And finally, then they can be worked upon in a multicentric model to determine how to prepare or develop faculty to be better evaluators. And finally, how to make assessment a continuous and integral part of medical profession. The present method of the councils awarding degree points, what are they known as? Some points for evaluation or attending a CME or attending a conference simply will not do. Credit points, yeah. This is hardly, whether you go or not, you get a certificate, you get 2 credit points. It is very easy to get credit points. Thank you. Thank you very much. Grateful for patient listening.
Thank you, sir, for a wonderful oration. I'm sure that you would have stimulated a lot of young minds to think about medical education, and as well as the senior faculty to be rethinking as to how they are assessing the students. On behalf of the National